Good morning, dear students. We start our lecture dedicated to the basic principles of the radiation therapy. I'm Mitsukulian, and today we will have two parts of this lecture. First part will be dedicated to the basic principles of the radiation therapy. After it, we will have a short break. Due to limitation of the Zoom conference, we must disconnect after the first part, and after that we will have a short pause, and all students must reconnect to the Zoom conference using the proper link. So in the first part of our lecture we will talk about the interaction of the ionizing radiation with the matter, mechanism of the radiation damage to the tumor cells, radiotherapeutical interval, indications and contraindications for radiation therapy, creating a schedule of the radiation therapy of the deep located tumors, and estimation of the focal dose and rhythm of radiation. So first of all, let's talk about the definitions. Radiation therapy is a type of cancer treatment that uses beams of intense energy to kill cancer cells. Radiation therapy most often uses X-rays, but protons or other types of energy also can be used. The term radiation therapy most often refers to external beam radiation therapy. What is ionizing radiation? Ionizing radiation is traveling as particle or electromagnetic wave that carries sufficient energy to detach electrons for atoms or molecules, thereby ionizing an atom or molecule. Ionizing radiation is made up of energetic subatomic particles, ions or atoms moving at high speeds, usually greater than 1% of the speed of light. As you can see on this diagram, you can see non-ionizing radiation spectrum and ionizing radiation spectrum of the electromagnetic different types of waves. When ionizing radiation interacts with the matter, it causes 5 different types of effects. First is ionizing, the second is heat effect, photoexciting effect, photochemical or chemical effect, and biological effect. We may use different equipment for the radiation therapy. Mainly we use different devices like X-ray machine for the radiation therapy, also gamma therapeutical device for the application in case of different tumors located in different parts of the body, and different types of the devices according to different type of radiation showed of this slide. I will not stop on it, and let's come closer to the issue of the radiation therapy and its clinical basis. So about 1/3 of all patients with cancer are relatively curable. Radiation therapy is used not in all cases. We may say that approximately 60% of oncological patients will be treated with the surgical methods in combination with the chemotherapy or radiation therapy. We call such treatment of oncological tumors as the combined treatment. And approximately 30% of all oncological patients are treated only with radiation therapy, and only about 10% are treated isolated with only chemotherapy. Radiation therapy is also used as a palliative measures. Now we will talk about the main methods of radiation therapy. We have different classification, and first of them is according to the type of radiation. We know that we may use different type of radiation as the photons, electrons, neutrons, protons, heavy nuclei, and we may divide it as X-ray therapy, beta therapy, gamma therapy, and radiation therapy with high energy radiation. According to the localization of the source of radiation, we may classify it as the distant. It means the source is located on the distance approximately 3 to 5 centimeters and up to 1-2 meters from the surface of the body, and contact type of the radiation therapy. For instance, if we use radiopharmaceuticals, and they may be placed directly into the tumor. The third is according to the type of administration of the dose. The close type of radiation, the source of ionizing radiation is located on this distance from 1.5 to 30 centimeters. Distant type if the source of ionizing radiation is located on the distance from 30 to 1.52 meters, and applicatory type if the source of ionizing radiation is located on the distance from 0 to 1.5 centimeters. The source of radiation is located directly on the irradiated surface, for instance, application of radioactive phosphor, thallium, and so on. According to the localization of the tumor, distant X-ray therapy is also divided into: first, superficial, if the pathologic focus is located on the depth of 1 centimeter from the skin surface; medium, if the pathologic focus, means tumor, is located on the depth of 3 centimeters from the skin surface; and deep, if the pathologic focus is located deeply from the skin surface, 10-15 centimeters. Now we will talk about the advantages of the high energy radiation. The first advantage is the effect of the skin sparing due to the accumulation of electrons under its surface. The second is a higher penetrating ability. The third is less scattering of radioactive particles, higher as the result accuracy of the bundle. And the last fourth is less difference in absorption in bones and soft tissues. If we will talk about the peculiarities of the influence of the radiation therapy on malignant cells, we must mention that one of the main effects of ionizing radiation on the tumor cells is inhibition of the cell duplication. Also, we may admit such effect as the quantity of the pathological mitosis will be increased under the influence of ionizing radiation, but soon these cells die as the result of chromosome aberrations, genetic mutations, alterations in the DNA structure. Also, under the influence of the radiation therapy, the quantity of so-called giant cells in tumor increases. We will talk about the giant cells a little bit later. These giant cells already lost their ability to divide, but still they grow further. The cell lost its shape and its functional type, increased in size, which leads to change in the permeability of cell membranes. Cores of those giant cells increased in size and are distributed as areas of the chromatin. Also, we may admit other effects on the tissues and cells under the influence of the ionizing radiation and the radiation treatment, such as the growth of the granulation tissue, which will be later substituted in place of the tumor, will substitute in place with the tumor cells. The tumor cells will be substituted with the granulation tissues. Also, blood supply of the tumor changed due to developing of the endophlebitis and proliferative endocarditis of blood vessels walls, which leads to obliteration of the vessel space and as a result to fibrosis and destruction of the tumor. Also, we will observe granulation tissue which will transform into connective tissue on later stage after the completion of the radiation therapy of the tumor. Here on this slide we can see the giant cells, we can see a large amount of cytoplasm, their nucleus spread through the cell, the parts of the patches of the chromatin. So we know that those giant cells are lost their ability to divide and will have the increased rate of the apoptosis. Here we can see the schematical presentation of the mitosis. We know that is the cell division in which the nucleus divides into nuclei containing the same number of the chromosome. In case of the radiation therapy, this process will be destroyed and it will be abnormal due to the increased number of the abnormal mitosis, abnormal of the mutations, aberrations, and in the result increased rate of the apoptosis inside the tumor. We can see here the example of the pathological mitosis under the microscope. Now we must talk about such important thing as the radiotherapeutical interval. What is that? It's the difference in the radiosensitivity of the normal and tumor cells and tissues. What is radiosensitivity? We will talk a little bit later, and we will give to it also definition. And radiotherapeutical interval is used in radiation therapy to destroy tumor tissue while preserving the surrounding normal tissue which is located around the tumor. Why is it important? Because often different severe complications may be observed due to the radiation therapy, like a necrosis of the surrounding normal tissues, like a burns, like inflammation, even resulting in abscess, and so on. So we must preserve normal surrounding tissues around the tumor to avoid such serious complications. We know that there are a lot of different factors that have a dramatic impact on the success of the radiation therapy and may play a very significant role in a treatment failure after the radiation therapy. Such important factor is a radiosensitivity of the malignant tumor. It's a property of the tumor cell. We have to respond to ionizing radiation. We know that there are different types of the radiosensitive and radio-resistant tumors. Generally, we know that tissues with a high proliferative rate, it means that tissues that divide very quickly, like lymphatic tissue, glandular tissue, bone marrow tissue, bowel mucosa tissue, have a very high radiosensitivity, and tissues with a very slow rate of division will usually will have low radiosensitivity. It means tumor which origin from the tissues with a high proliferative rate will usually have high radiosensitivity. They will respond to radiation therapy very well, like a seminoma, lymphocytic lymphoma, other lymphomas like leukemias, myeloma, and such tissues like tumors like a hepatoma, glioma, and some other sarcomas usually will have, unfortunately, very low radiosensitivity. It means that we usually will not use radiation therapy to treat such kind of the tumors. Here we can see different examples of the radio-resistant tumors like a melanoma, glioma, and sarcomas of the soft tissues in adults. In these cases, we will usually not use radiation therapy to treat such tumors. And also we have other different factors which have a very important impact on the effect of the radiation therapy and how good or bad this tumor will respond to the radiation therapy, such as the size of the tumor. Usually small tumors are better treated with radiation therapy because in large tumors there is a big possibility that some cells are in a hypoxic state or in a G0 resting period, which reduces their radiosensitivity. Also, location of the tumor plays very important role in the if this patient will be sufficiently cured. Curability depends on the surrounding tissues radiosensitivity, as we already know. For example, radiosensitivity of the vaginal mucosa is relatively low. That's why initial stage of the cervix uterine cancers are highly curable with the radiation therapy. Treatment of the malignant tumors may be performed by following algorithm. First type of the program of the treatment, it's a radical type of the treatment. Radical treatment is directed on total destruction of the tumor elements and total recovery of the patient. Unfortunately, such kind of the therapy usually can be used only on the initial stage of the tumor if those tumors show high radiosensitivity. On the late stage of the tumor, when the tumor is already infiltrated into the surrounding tissues, usually radical treatment is not possible. So the second type of the treatment is palliative, which is directed on the delay of the tumor growth in incurable cases. And the last third program or type of the treatment of malignant tumors is symptomatic, which is directed on relief of severe clinical symptoms caused by generalization of the process, like bleeding, like pain, and so on. We have different types of the radiation therapy, and one of them, very interesting type of therapy, it's a brachytherapy. It's the usage of the closed radioactive sources. We can see on the lower part of the slide the special seeds, radioactive seeds, which will be introduced directly into the tumor, into the organ which carries the tumor, and they will emit radiation and kill the tumor cells. Later, those seeds could be extracted. And the alternative type, of the therapy of the malignant tumors. It's a systemic therapy. It means the usage of the opened radioactive sources. So, in short, brachytherapy is used for the irradiation of intracavital spaces, for example, treatment of the corpus of cervix of uterine cancer, for intratissue implants, for instance, in case of breast cancer, tongue cancer, or for application therapy of the available tumors. And alternatively, systemic therapy is more limited in use, and it's only used for treatment of the thyroid gland cancer, polycythemia, and some other rare cancers. So on this slide you can see the schematical presentation of the brachytherapy process. This is USG probe, which is introduced rectally. Here we can see the special needle, which carries the seed with a radioactive element, which will be introduced into the prostate. Here we can see the prostate. In case of prostate cancer, 20 or even more such radioactive seeds will be introduced into the prostate and left there. So those seeds will emit radiation and will try to kill the tumorous cells with this kind of the treatment. And here we can see the different isotopes which are used as the closed sources of ionizing radiation. Here you can see the different types and names of isotopes like cesium, cobalt, gold, indium, radium, radium, strontium, thallium, yttrium, and type of radiation which they are emit. And also we can see the isotopes for open sources like phosphor, strontium, aurum, and types of radiation. You can see that mainly it's a beta and sometimes gamma radiation, like in case of iodine 131. A few more words about the main points of the radical therapy and how we perform this kind of the therapy. First of all, the doses of this therapy should be really high, approximately 60, 66 or even more grays if we talk about the whole dose, total dose applied of the tumor, which should be divided into the fractions. It means the smaller doses, approximately 1.5 or even less grays, divided into the 33 procedure during 6-7 weeks. So how we will calculate how many grays is per one fraction? We just divide the total amount of the grays, total dose, into amount of the procedures, and in the result we will receive the dose per one fraction. In case of the combined therapy, for example, if we use chemotherapy as a basic method and radiation therapy as additional method, is used with the aim of the eradication of the residual malignant cells in the, for instance, meningeal spaces where cytostatics doesn't reach, for radiation of the, for instance, skull in the acute lympholeukemias, small lung cancer, and so on. Palliative therapy by means of irradiation is performed in incurable cases, for example, if in case of metastasis in bones, esophageal cancer, lung cancer, in patients suffering from some symptoms which irradiation therapy may relieve or reduce, such as pain, for instance headache in case of brain cancer metastasis, but pain caused by direct invasion of the tumor into the skull bone is less sensitive to such kind of therapy. Or, for instance, to relieve the obstruction in case of, for example, esophagus stenosis, lung atelectasis, compression of the vena cava superior in case of lung cancer, and so on. Or for instance, in case of compression of the ureter in case of the cervix, uterine cancer, or cancer of the urinary bladder, or in case of the compression of the pyloric part of the stomach due to, for instance, lymphoma. Also, palliative or symptomatic therapy may reduce chronic bleeding, for in case of unusual, in case of cervix, uterine cancer, urinary bladder cancer, larynx, bronchial cancer, oral cavity cancer, and other cancers. May reduce bleeding in case of ulceration or even stop this process of ulcering. In case of pathological fraction, radiation therapy may be prophylactic in case of myeloma or Ewing sarcoma. To treat neurological disorders in case of metastasis from the breast cancer into retrolobular tissue, in case of such systemic symptoms as myasthenia due to thymoma, which is very sensitive to radiation therapy, night sweats, hyperporexia, and so on, and also may be used to decrease the intracranial pressure. Here we can see the ulceration due to the superficial skin cancer. Here on this slide we can see very important classification of the patients and their annual tolerance doses to the radiation. In this column you can see the name of the group A, D, B, D, C, D, or DD, and in this column you can see the definition. For example, the AD group is a patient who are diagnosed in concern with oncological disease or precancer condition, differential diagnosis of the congenital cardiovascular pathology, wall effects, urgent practice, vital indications. In this group of patients, the maximal annual tolerance dose is 100 millisieverts per year. It means that we should not exceed this dose if we perform diagnostical test, which means that we will use ionizing radiation during the diagnostical process. This dose we must take into the account when we got an oncological patient in whom we plan to apply radiation treatment, so we must take into the account already achieved by this patient dose. PD, it's a patient who is already diagnosed with a non-oncological disease or differential diagnostics of the non-oncological disease. In this group of patients we may use only 20 millisieverts per year for the diagnostical purposes. Patients in group CD, patients with the oncological patients after radiation therapy, or patients with the risk factors, workers in harmful environment. In these patients we may use dose only 2 millisieverts per year. And in DD group, it's a screening, examinations, volunteers, scientific researchers or participants, only 1 millisieverts per year of the radiation dose could be used. Also very important classification is categories of workers, depending where they work. We have three types of the categories. A, it's a personal, those who directly work with the sources of ionizing radiation. B, it's a personal, the specialist whose places of the work are located close to the sources of ionizing radiation, but not directly. And C, it's all population of the people which are not connected to the ionizing radiation. This was the first part of our lecture. Now we will have a short break. Please disconnect from our conference, and then in a few minutes please reconnect to it in order to continue listening to the lecture. Dear students, we continue our lecture. The second part of our lecture is dedicated to the direct application of the radiation therapy. We will discuss the radiation therapy of the thyroid gland conditions, abnormal conditions like thyroid gland cancer. And before that, let's say a few words about the thyroid gland itself. The thyroid gland is a gland in the neck that produces two hormones that regulate all aspects of the body's metabolism, the chemical process of converting food into energy. When a thyroid gland is overactive, it produces too much of those hormones, accelerating the metabolism. Let's talk about the radiation therapy, which we may use to treat different conditions of the thyroid gland, different pathological conditions. First of all, let's talk about the radioactive iodine, radioiodine 131. It's the isotope of the iodine, which could be used for the hyperthyroidism. And how is it now used? First of all, we need to mention that radioactive iodine 131, also called as the radioiodine therapy, is a treatment for an overactive thyroid condition called hyperthyroidism. Hyperthyroidism can be caused by the Graves' disease, in which the entire thyroid gland is overactive, or by nodules within the gland which are locally overactive in producing too much thyroid hormone. Radioactive iodine 131 is an isotope of iodine that emits radiation and is used for the medical purposes. This type of isotope emits gamma radiation. When a small dose of the iodine 131 is swallowed, it is absorbed into the bloodstream, in the gastrointestinal tract, and concentrated from the blood by the thyroid gland, where it begins destroying the gland's cells. There is no special equipment used for such kind of the radiation treatment, and the patient simply swallows a prepared dose. There are some principles of this kind of the treatment. First of all, patient will be able to return home following the radioactive iodine treatment, but he or she should avoid prolonged close contact with other people for several days, particularly pregnant women and small children. Why? Because the half-life period of this isotope, which is actually incorporated inside the patient's body, will emit the radiation during the few days after the patient will swallow it. The second is the majority of the radioactive iodine that has not been absorbed leaves the body during the first 2 days following the treatment, primarily through the urine. It means that this urine also should be stored separately and preferably far away from the children and pregnant women, because this urine also may emit radiation. Small amounts of iodine 131 also will be excreted in saliva, sweat, tears, vaginal excretion, and feces. Radioiodine therapy is not used in a patient who is pregnant. When given to a nursing mother, radioactive iodine can reach a baby through the hair, breast milk. Also, it is recommended that pregnancy be delayed until at least 6 to 12 months after radioactive iodine treatment. What result we may achieve after the radiation treatment with the radioactive iodine? Patient may experience some pain in the region of thyroid after the application of this kind of therapy, similar to a sore throat. They should ask their physician to recommend an over-the-counter pain reliever to treat this pain if it should occur. It is highly likely that some or most of the thyroid gland will be destroyed with this procedure. Since hormones produced by the thyroid gland are essential for metabolism, most patients will need to take thyroid pills for the rest of their life following the procedure. It means that they will be on the hormone replacement therapy till the end of their life. Thyroid pills are inexpensive, and patients will typically be instructed to take one per day, and there are essentially no other permanent side effects from the procedure. But sure, if you talk about such severe effects like bleedings or necrosis and so on, but if we talk about the risks, for sure all kind of the radiation therapy using X-ray waves or gamma waves may increase the risk of this patient to have the radiation-induced cancer, and we must always inform our patient about this risk, because there is no actually minimal threshold of the developing of cancer after the radiation therapy, so no minimal dose threshold. On this slide we can see the scanograph or scanning of the patient after the administration of the radioactive iodine 131 and its accumulation in the region of the thyroid gland on the posterior and anterior views. We must say that application of the radioactive iodine therapy in a benign condition like hyperthyroidism is a relatively rare type of the therapy, used only in exceptional, very well selected cases, and also only in case of the very severe natural history of the hyperthyroidism. More often we use radioactive iodine therapy in case of the cancer, thyroid gland cancer, and as written on this slide, such kind of the therapy is usually used for the treatment of the thyroid gland cancer, also for the treatment of the thyroid remnants or of the metastatic thyroid cancer. We must mention that this ablative therapy should be given to all patients with a iodine-avid thyroid or malignant tissue in the neck or elsewhere, or in those patients who immediately after the surgery and have no evidence of iodine-avid thyroid tissue, but who have elevated serum thyroglobulin levels. Which kind of the surgery and what is thyroglobulin, we'll talk a little bit later. So on this slide we can see the normal thyroid tissue presentation on microscopy and how the thyroid gland cancer looks like. Let's talk about the treatment of the thyroid gland cancer. So the primary treatment of the thyroid gland cancer is thyroidectomy. It means surgical extraction of the whole thyroid gland. But following thyroidectomy, almost all patients have functioning iodine-avid thyroid tissue in the neck, and it is impossible to distinguish, except by histopathological examination, between normal and malignant thyroid tissue. So we know that many patients will have remnants, residual thyroid gland tissue in the neck, which may carry cancer cells. So eradication of all thyroid tissue is essential because both normal and malignant thyroid tissue produce thyroglobulin, a marker for thyroid cancer. It will permit accurate diagnosing and uptake of therapeutic radioiodine by malignant tissue, maximizing the therapeutic benefit. Here we can see on the upper picture the example of the thyroid gland cancer and the surgical procedure. The issue of sensitivity is very important in case of radiation treatment of the thyroid gland cancer. We know that most differentiated thyroid cancer, like papillary and follicular cancers, have different ability to concentrate of radioactive iodine. And we also know that so-called Hürthle cells and Toll cell variants of differentiated thyroid cancer may not concentrate iodine at all. It means that before the radiation therapy, we always must take into the account the histological pathological conclusion made by the pathologist and analyze the type of the cells, because you may know that different tumors, even of the one organ, may have different histological nature and different grades of differentiation, which may have very important impact on the radiosensitivity and efficiency of the radiation therapy. Here on this picture we can see the iodine 123, which was used for the diagnostics of the whole body, which demonstrates no abnormal focus of activity to suggest metastasis. But application of the radioactive iodine 131 post-treatment whole body images demonstrate multiple abnormal foci of activities, these bright focuses, consistent with the extensive cervical lymph nodes and pulmonary metastasis. These findings confirmed by subsequent computed tomography images. So it means that in this patient there is the spread, advanced disease, and metastasis in the lymphatical nodules are presented as the bright focuses, bright nodules on this image. We have contraindications for the radioactive iodine therapy. Among them, there is absolute contraindications like a pregnancy or lactation, and also relative contraindications if the patient on thyroid hormone replacement therapy. Those patients may be treated with a stimulation by the recombinant human thyroid-stimulating hormone, and in this case we should also avoid application of the radioactive iodine therapy, or at least postpone it. We use high energy collimator for this kind of therapy, and a radiopharmaceutical such as the iodine 131 in a form of sodium iodine, which will be administered orally or in liquid form or in a form of capsule. And the procedure looks like after demonstration of the iodine-avid thyroid tissue, normal or malignant, using the gamma camera or whole body counter, as you seen on the previous image. We may achieve this information about the accumulation of iodine in the tumor cells. We must prepare the patient, and for the definitive thyroid first step, it's a definitive thyroid surgery, usually total or radical thyroidectomy. We have such a precautions like we should not use skin sterilization with the iodine containing compound during the surgery. Stop thyroid hormone replacement therapy for at least 4 weeks prior to the radioactive iodine therapy. We should not use the intravenous contrast before the at least 2 months prior to the evaluation and therapy with the radioactive iodine. And we also should reduce the iodine contained in the patient diet, for instance reduce seafood or shrimps and so on. The second step in preparation is estimation of serum thyroglobulin prior to administration of the iodine 131 tracer. Third, we should perform tracer study to ensure the radioactive iodine uptake in thyroid tissue or in metastatically diseased tissue. 4. Diagnosis of residual thyroid tissue. Smaller doses of the radioactive iodine of 20 to 80 megabecquerels are given, and while bigger doses like 80 to 200 megabecquerels are given to evaluate a metastatic disease. And the fourth preparation step is iodine 131 is given orally, then NEC uptake and imaging is carried out between 24 and 72 hours after the administration. We must perform whole body images after 72 hours using gamma camera or special scanners or SPECT device. After that, after the preparation, we perform the therapy. Ablative therapy performed right after definitive surgery. Usually a fixed dose between 1 and 4 gigabecquerels of radioactive iodine 131 is given, or dose may be estimated using ultrasound. For example, 30 to 50 grays should be delivered to thyroid residual tissue. Here on this graph you can see the different columns in 2 different studies, showing to us the percentage of the patient with a complete response after the which underwent the definitive surgery, thyroidectomy, and also after that radiation therapy with the radioactive iodine was performed. In all those 2 types of scientific trials, we have seen most equal results, with approximately 80% of the patient received complete response, which It means that it was very efficient kind of the treatment. Approximately 60% of the patient got a partial response, means not all of the cancerous cells were killed by the radioactive iodine, and only in 2 or even 0% of the patient there was no response. So means the main part of the patient responded very well to such kind of the treatment with the radioactive iodine. And how we may assess the response to the treatment, we will talk right now. So we have different rules for the control of such kind of the therapy. Patients should be evaluated not earlier than 6 months after the ablative therapy with the radioactive iodine 131. Therapy is considered successful if 2 successive negative whole body scans are shown non-measurable non-measurable thyroglobulin level separated by intervals of 6 months. And also then patient is managed by serum thyroglobulin estimations 2 times a year for a period of 5 years, then annually for at least 5 years. So as you may see, oncomarker thyroglobulin plays very important roles for the surveillance of the patients after the radiation therapy. Unfortunately, as any radiation therapy with radioactive iodine have different side effects, and among them different, usually short-lasting side effects that last less than 1 week. For example, transient exacerbation of the thyrotoxicosis and apparent thyroid so-called storm, which may occur within the days of the radioactive iodine therapy in patients who were not made euthyroid before the therapy. Also, we may observe mild pain and tenderness over the thyroid or salivary glands. Also, we observe sometimes dysphagia. Also, exophthalmos may be worsened. Pretreatment with the antithyroid drugs may prevent this complication, as may administration of prednisone. Steroid pretreatment is now advised for any patient with the exophthalmos. Also, we may perform steroid administration, and it should be likewise considered if pressure syndromes to the trachea are anticipated or have set in. Here on this slide we can see the presentation of the thyroid gland cancer and application of radioactive tracer on the positron emitted tomography and on the scan using the scanography. And this is one more example of the accumulation of the metastasis due to the thyroid gland cancer accumulated in the neck, also on the PET, positron emitting computed tomography. Post-therapy follow-up should be carried according to following rules. Hormone replacement therapy may be resumed 2 days after the treatment. Thyroid function test carried out every quarter to ensure adequate suppression of the thyroid stimulating hormone by thyroid hormone, and patients should be followed on the level of the mild thyrotoxicosis. Also, we should estimate the serum of thyroglobulin level, as it was said before. Also, very important to evaluate the hematological status, and it should be carried out between 4 and 6 weeks after the therapy. And also, patients are usually not retreated earlier than 6 months after the therapy. It means that a small amount of the percentage of the patients with a partial response, if we will see increasement of level of thyroglobulin sometime after the radiation treatment, in those patients we may apply secondary radiation treatment with the radioactive iodine, but not earlier than 6 months after the initial therapy. Here on this slide you can see the nodule on the thyroid gland and the extracted thyroid gland with the thyroid gland cancer. It was the last slide. I thank you for your attention, and we'll see you on the practical seminars. Thank you and goodbye.